Good evening, everybody. Welcome again to our latest session. This one is an awesome one, as they all are. Before we start, I want to say one thing. I was told earlier this evening that one of the people in the audience, I will not identify him, told me that a good friend of his was having some neurologic symptoms a couple of weeks ago, and he was not ready to do anything about it. He told his friend, get to the nearest hospital ASAP. His friend got there and recovered 100% from his whatever was he had, whether it was a mini stroke or an early stroke or whatever. So we do help some people once in a while. Rabbi Rosenberg's coming in, but this session is one about cancer. We should say the word. We shouldn't call it the awful sickness or anything like that. We have to face it. And we are privileged to have three people here tonight who will give you different aspects of it. We have a radiation oncologist, a medical oncologist, and a genetic counselor. We're going to start off with our radiation oncologist, Dr. Stephen diBlase, not de Blasio, diBlase is our new chairperson of radiation oncology. He's got wonderful toys to play with. When I was a medical student, we had a medication called 5FU, and we had radiation machines that were that big and did nothing. We have all kinds of wonderful technology and ways to help people with this awful disease called cancer. And we have him in Queens now, Dr. diBlase.
Thanks, Dr. Mel. Thank you.
Please hold your questions till later.
So you won't use it against me. My name is almost rhymes with Mr. de Blasio, the mayor of New York. But so it's great to be here. I joined New York Presbyterian Queens in July, so I've been here now about going on 5 months, and it's just great doctors to work with and a tremendous program. So I want to talk about radiation treatments, radiation oncology. From sort of a 30,000-foot view. Radiation can get very technical where you're going to be scratching your head, so I'll try to keep it very general to talk about some of the newest things going on in the field of radiation oncology to treat cancer. And just to give you a sense, about half of cancer patients get radiation. So it's a common modality, and it's used in all sort of stages and all indications of cancer. So just to give a quick background about me, I trained in Philadelphia, a place called Hahnemann. Now it's called Drexel. In Philadelphia, as many cities, the academic institutions keep changing. I did my training in Philadelphia at a place called Thomas Jefferson, and then I've been on faculty at quite a few places. I go through jobs quicker than Liz Taylor goes through husbands, but most recently at Tulane University and in New Orleans, Louisiana. And I'm glad to be on faculty at Weill Cornell also at this time. So my professional interests are largely involving prostate cancer. I had a previous NIH grant utilizing very advanced MRI imaging to guide radiation to treat prostate cancer, a form of MRI called MR spectroscopy, which looks at sort of the chemical makeup. I have a strong background in radiosurgery, which is very precise radiation to treat tumors, either the brain, the lung, or other parts of the body. I've experienced a lot with CyberKnife and Gamma Knife. You'll hear those terms used a lot on the TV set. I will tell you, this part of the country has more advertising for radiation than anywhere in the United States. So if you want to learn about radiation, just turn on the TV set to become educated. I currently review radiation centers throughout the country for the American College of Radiology. So I go in with a group of a physicist and myself, and we review the procedures, the quality, to make sure everyone's crossing their T's and dotting their I's. And that's given me a good perspective in terms of how things should be done, in terms of safety and quality assurance. And you also realize that, you know, there's many ways to run a successful, safe center. Just to give you perspective, this was an experiment by Pierre Curie back in 1901. It's the first documented radiation biology or radiation treatment on a person in the world. 1901, and this is Pierre Curie, and the other gentleman is a gentleman named Becquerel, who is also a famous name in science. But this is the first experiment where radiation was applied to a human. He actually applied a radium tube to his forearm and documented that it created an ulcer. And from that, in 1901, became the sort of the initiation of radiation to treat tumors. This is the first use of a linear accelerator. That's the machine that delivers radiation to treat tumors. This was in Stanford in 1956, and this is Dr. Stanley Kaplan. He utilized this large machine. Let's see if I can find my other pointer. Here, a very sort of archaic, very imposing machine here.
Oh, there's a button there also.
Oh, wow, excuse me. Oh, right here. Ah, perfect. So to treat this little boy here with retinoblastoma, sort of a tumor in the eye with radiation. So this is the first use of radiation, 1956. We've come a long way, and you'll see now, this is sort of a picture from about 10 years ago, but this is sort of the modern linear accelerator. We call it the LINAC, but it's where radiation comes out and delivers, treats tumors. Radiation comes out from this opening here, and people typically lie on a table we call the couch, but that's where you get your radiation treatments from. I have the pleasure of working at the Department of Radiation Oncology. It's the Julia and Ned Arnold Center for Radiation Oncology. It's really a tremendous center off the side of New York Presbyterian Hospital. This is our front entrance. That's our lobby. And it's on the back side of the hospital. It's a separate entrance. It's really a tremendous department and location for cancer therapy. The department holds 20,000 square feet. We have 3 linear accelerators. We have our own CAT scanner to scan, to set people up for radiation, a treatment room, 6 exam rooms. We have a dedicated suite for doing brachytherapy. That's the internal radiation that we put in, whether it's radioactive seeds or different internal radiation. And then we have a recovery room. We actually have an anesthesia machine. We have a whole sort of an OR setup to do radiation if it's internal. The staff at our center, we're 4 board-certified radiation oncologists, 12 therapists that do all the heavy lifting with the daily treatments and setting people up, 3 registered nurses, and a whole support staff to let us do what we do. So I'm going to show you a picture. This is our newest machine called the TrueBeam. And it's really state-of-the-art. It's the only one really in the Long Island, Queens location, but you can see the person on the machine, and the machine goes around typically in about a minute, and has a CAT scanner built into the machine that's doing a constant image of the tumor going around to get a CAT scan image. And we use that image to set up the radiation every day right before treatment. So it's a very elaborate machine, very accurate, and you get a scan before every treatment. So if you get 10 treatments every day, you're getting a CAT scan before those treatments. So very elaborate, very precise. It allows us to do treatment, what we call rapid arc, but basically the machine goes around once or twice in about 2 minutes and does all the radiation, which usually took us in the past 15, 20, 30 minutes. Now it's done in about 2 minutes. So very accurate, very complex computer systems to do that. The TrueBeam, we're very excited to have it. We installed it in July of this year. It's very advanced. It has the couch. This is where you lie on during the radiation. It's a very elaborate setup system to set someone up for treatment. The accuracy of the whole system when you're lined up is less than a millimeter. So very accurate when you're set up with all the imaging and the setup. Less than a millimeter of error in the precision, and that's pretty tight in our world of medicine. You'll commonly hear of a term called stereotactic body radiation therapy, or SBRT. That just means delivering radiation very precisely to a tumor in the lung or in the abdomen or even in the head with very precise guidance. And this picture kind of gives you a sense of what we're talking about. In the past, if there was a tumor in someone's right lung, we would treat a big field. We couldn't miss it, but we were treating a lot of lung. Now, very small fields, which you can see on the other side, to treat tumors so that we treat the tumor and minimize side effects to the normal body. This area of lung radiosurgery, when tumors have gone to the lung, is a very common problem, and now we treat these tumors typically in 3 or 4 treatments over about a week's time to get people back to their lives. So there are studies now showing that for people that don't want surgery, doing this lung radiosurgery, say in 3 treatments, has sort of comparable, sort of effects or efficacy, as we say, to surgery. So you don't always need surgery when you have a lung tumor. You can get sort of an outpatient, non-invasive approach, which I would argue is very effective in a lot of people. We also use this precise radiosurgery, which is focused radiation, to treat brain tumors, utilizing a lot of advanced technology and setup to do it. We also can use it to treat multiple tumors in the brain quickly, where in the past you need to get surgery. Now we do it in a few minutes in the brain. So a very exciting area in the field of radiation oncology is called proton beam therapy. And protons is a unique type of radiation particle that goes into the body and delivers its radiation in a very discrete manner. Right now there are about 25 proton centers in the country. New York is finally jumping on board on that bandwagon, and this upcoming year in Harlem there's going to be this New York Proton Center. And I just wanted to kind of give you a sense of what's happening out there. There's one in Philadelphia at University of Penn. There's typically, right now there's about 25, but this is where the field is going. It's very elaborate treatment, and this you could get a sense of, it's a big machine which rely on getting this treatment. Just to give you a little bit of the science behind protons, on the left is a proton beam radiation, and it's hard to see with these lights. I don't know if we can...
Yeah, the problem is it doesn't come out, and this if I turn the lights off, this doesn't come out.
Oh, alright, so basically...
That's why I can't.
The proton beam comes out of here, it hits a tumor, and nothing goes past the tumor, where with normal radiation, oh great, perfect. You can see that when a proton beam goes out, it stops right after the tumor, so all this area is not getting any radiation. Whereas with normal x-rays, you shoot a beam, it kind of goes through, and the rest of the body gets radiation. So that simple sort of schematic there gives you the sense of what protons or why they're different. And this is kind of another example. Children, if you go to St. Jude's or a lot of pediatric cancer locations, will typically try to treat the spine where the radiation goes in. We call it cranial spinal radiation. And this is an example where the proton beam goes in and stops right at the back, right at the front of the spine. Whereas the other, if you're not in those 25 centers in the country, when the beam comes in, it goes right through. So the whole abdomen, the whole body's getting radiation. And when you're 5 years old and you're getting treatment to the spine, obviously you want your radiation beam to stop here and not treat the whole body. So that's why places like Mass General and Harvard, in certain places that have this technology, and especially in the pediatric population, which I think is the real indication for this advanced proton therapy, it's really meaningful. Because obviously, if you have a 5-year-old that's having radiation sprayed all throughout his belly, what's that going to do to someone 30, 40, 50 years later, which is not good. This is another example of using protons to treat a brain tumor. This is the proton treatment. This is the normal treatment. You get a lot more radiation than the other parts of the brain. This gives you a sense of the science. I could spend a lot and probably give people here a lot of headaches, but basically the way protons work is something called Bragg's peak. Basically, the energy goes to a very focal point and drops off. So protons have a very discrete path. They go in, they deliver their energy, and then it falls off to zero very sharply. And this Bragg's peak is the whole science behind why protons are at least, in terms of sparing normal tissues. Whereas photons, conventional radiation, the beam never really stops. It keeps going off. So all this part of the body, this sort of beige color here, gets radiation. I don't know if many of you are familiar with California. This is the Scripps Clinic. This is their proton unit. Just to give you a sense of how big these things are when they're being put in, it's about 25 tons. You can see a person here. And this is the cyclotron being dropped in at Scripps in La Jolla. They have a proton machine. And it's a very heavy, very expensive apparatus, but that's their machine being put in. Kind of give you a view of the machine being dropped into this large vault. These are people, and this is it coming down, this 25-ton machine going into the vault to do it. So needless to say, protons are very expensive. Typically, proton centers run between $50 and $100 million. So it's really not for every hospital, not for every location. You won't see many in rural Kansas, nonetheless. So I call it kind of, in hospital terms, financial Darwinism, or hospital Darwinism. Most hospitals can't afford this, so hence it's a very select treatment. Whether the healthcare system can afford it is a whole other debate, but it's happening in certain places. These are the centers, these are the locations in the country. This is about 2 years old, this slide, but it gives you a sense of where the proton centers are. So if you have any rich uncles or cousins that want to invest in a proton center, this might be the area to put it, but maybe you can put one in Las Vegas and have a wealthy gambler try to pay for it. But you can see that's where they are right now. About 25 are ongoing right now. I just want to switch gears. One of the things we're offering at Queens, at NYP Queens in our department, is something called Xofigo. It's a treatment for prostate cancer that's spread to the bones, and it's a liquid radiation. It's an intravenous liquid form of radiation that we give once a month to treat cancer of the prostate. It's called Xofigo, and it's basically liquid radium. And in 2013, it got FDA approval. So for men that have prostate cancer that's gone to the bone, this is a once-a-month treatment. It takes about a minute to get it, and it's an intravenous form of radiation that seeks out areas that have sort of metastatic disease to treat it. It's very well tolerated, and we're glad to offer it now at our center. And the way it works is this radium liquid goes to active areas of turnover, and it mimics calcium, and it goes selectively to these areas to give a very high potent form of radiation called alpha radiation. And you can see sort of it kind of seeks out areas which are actively turning over utilizing radium. It mimics calcium. It uses alpha particles, which is a very small, it's a form of radiation, only goes about 10 cells in distance, so very precise, and it creates DNA breaks and make tumors to do its thing. Big study that was performed called Alsimca, but basically I just show you the graph. The dark blue graph here is the advantage of getting Xofigo over placebo. It was a randomized trial in cancer treatment. We always want to see trials that compare placebo to the actual thing. And in this study, it showed an advantage in survival by getting this medicine. So besides its effects to palliate and make people feel better, it actually improves their survival or longevity. So it's a very successful medication that we're excited to offer at our center. Just to end the talk, I just want to give you some of the things we're doing in partnership with Weill Cornell in Manhattan. The hot area in radiation now is combining radiation to a tumor and combining it with immunotherapy. We call these PD-1 inhibitors. And what we're doing now is, and you've probably seen commercials on the TV set, Keytruda, Opdivo, these medicines that stimulate your immune system. Well, what we're doing now is, just say someone has a few tumors in their body, we'll radiate one of the tumors with these immunotherapy agents, and then the other tumors in the body shrink. So we're trying to create an effect where we help support the immunotherapy with radiation. The chair at Weill Cornell, Silvia Fermente, is a world leader in sort of looking at these treatments where we're combining radiation with immunotherapy to help improve response rates. And this is a slide just showing the sort of the immune mechanism behind that. So, great. Hopefully I didn't confuse anybody, but I just wanted to give you a sense of what's going on, and thank you. And I guess, yes?